I'm absolutely honoured to introduce our distinguished keynote speaker. Arya Sharma is a Professor of Medicine at the University of Alberta. He's also the Clinical Co-Chair of the Alberta Health Services Obesity Program. Dr. Sharma is Founder and Scientific Director of Obesity Canada, a network of over 10,000 researchers, health professionals and other stakeholders. He is the past President of the Canadian Association of Bariatric Physicians and Surgeons. Dr. Sharma is the leading voice in obesity science and medicine, has authored and co-authored more than 400 scientific articles, and has lectured widely on the etiology and management of hypertension, obesity, and related cardiovascular disorders. Dr. Sharma is regularly featured as a medical expert in national, international TV and print media. Please welcome this morning Professor Arya Sharma.
Well, thanks, Stephen, for the introduction and the opportunity to come back to Sydney. Good morning to all of you. So I was tagged this morning to talk about the issue around how do we diagnose and define obesity, because we have to move beyond numbers. And that's what I want to focus on in this presentation. I'm not going to be talking a lot about treatment, although I'm happy to take questions on treatment. There's going to be other presentations that focus more on those aspects. Here are my disclosures. We all know that excess body weight can lead to all kinds of health problems. And in fact, it doesn't matter what part of medicine you're involved in, whether you work in cardiology, whether you work in orthopedic surgery, whether you work in gynecology, obstetrics, oncology, even if you worked in forensic pathology, you're going to see that over the past several decades, patients have become larger. And every single organ system can be affected by excess weight. Reproduction, metabolism, joints, the entire cardiovascular system. There can be skin issues. One way of characterizing the complications of obesity is to think of them in terms of what we've described as being the 4 M's. People with obesity can have mental health issues. You can have metabolic consequences from excess weight. You can have mechanical problems. Think of sleep apnea, think of reflux disease, think of osteoarthritis. And there can be effects of obesity that are relevant to your milieu, the way you function in society. Now, if there's one thing that we've learned about obesity, is that yes, there are a long list of problems that patients can have. But not every patient has all these problems, or not every person who's large has all these problems. And that poses a dilemma in terms of actually making a diagnosis. Now, why do I use the term diagnosis? Because as medical professionals, we're trained to diagnose conditions. And in the last several years, there's been a push towards redefining and reclassifying obesity, not just as a risk factor. Smoking is a risk factor. Smoking is not a disease. To something that is actually called a disease. And in fact, a couple of years ago, the Canadian Medical Association came out and said, we've got to start thinking about obesity as an actual chronic disease. Why chronic? Because obesity, once you get it, and once you have it, once you put on the extra weight, there does not seem to be a permanent solution that would actually cure your obesity. And that has to do with the neurobiology of obesity. Bodies don't like to lose weight. And we understand not only are there complex drivers of weight gain, but we also today understand that there are very complex defense mechanisms that jump into action every time you try to lose weight. So your body doesn't care how you gain the weight. Your body doesn't care whether the weight is good for you or not. But it does care very much about keeping you at that weight. And that has consequences for management. Because as you all know, the problem in obesity management is not how do I lose weight. Everybody can lose weight. Everybody's lost weight. The problem is keeping the weight off. And the challenge of keeping the weight off, apart from continuing to live in this obesogenic environment is your own biology, so as you start losing weight, as you trick your body into losing weight by cutting calories, by doing an exercise program, by having bariatric surgery, your body is going to work against you because your biology does not like that, and it'll sabotage your efforts. And what we've learned from long-term studies is not only do we understand the mechanisms that your body has to defend against weight loss, but those very same mechanisms are going to set you up for weight regain. And in most cases, the body is going to win, which means in most cases, the body is going to put the weight back on. If I were to lose 5 pounds, my body's not going to like it. It's going to eventually put the 5 pounds back on. That's not a personal failing. That is normal biology. And we need to understand that. And that's where the whole idea and notion of this being a chronic disease comes from. It's not philosophical. It's based on the understanding that we have to manage obesity as a chronic disease. But I want to focus in my presentation today on the issue around diagnosis. So when the Canadian Medical Association, after much debate, came out with this statement saying we have to think about obesity as a chronic disease, and there are lots of implications of this kind of announcement. They also were careful to make one important point, and that is with regard to how we actually make the diagnosis. So body mass index, which you're all familiar with, may be a useful operational definition. It's great when you do population studies. If you want to know, are there more people living with excess weight in Australia, and you show me that the average BMI across the population is increasing, I will tell you, yes, there's probably more people living with obesity. But when you take this down to individual people in your practice, there's a problem with BMI. And I want to discuss those problems. It may be less of a problem when you deal with severe forms of obesity, when someone has a BMI of 50, as in my clinic. The clinic I work in is a bariatric clinic, so our average patient has a BMI of 50. Now, amongst people with BMIs of 50, as I'll show you in a minute, the likelihood of still being healthy despite the excess weight is small. It's not impossible, but it gets smaller and smaller with higher BMI. But when you talk about people with BMIs of 30 or maybe 25 to 30, knowing someone's BMI does not really tell you much about someone's health, and that has a problem when it comes to diagnosis. So one of the things we've known for a long time is that when you look at the phenotype of excess weight, that there's a lot of diversity and heterogeneity. And people have, for a long time, have been trying to come up with different classification systems for how to best describe obesity in a clinical context. So one of the things we've known for an extremely long time, and this goes back to the 70s, is that when you do a fat biopsy on 2 people of equal weight, you will find people who have a lot of fat cells, but these cells tend to be small. And if you look for signs of inflammation in the fat tissue, you won't find it. And then you can have someone who's got the exact same amount of body fat, and you do a biopsy and you look at the fat tissue. The fat cells are bigger, and there's signs of inflammation. And so you can actually differentiate between hyperplastic and hypertrophic obesity, whereby the hypertrophic obesity is the one that appears to be more, or people with hypertrophic obesity tend to be more prone to the metabolic issues. There have been attempts to look at body habitus. In fact, if you go back to the old weight height tables that we used to define ideal weight, they had different levels of body weight and height for different body frames. It never went anywhere, but it's important to remember that people have different body shapes. And those body shapes can actually determine where, when you put on weight, the weight goes. You're all familiar with the concept of central and peripheral obesity. We've got male pattern obesity, female pattern obesity. I think what we've really come to realize in the past several decades, thanks to imaging studies, is that it's not really a disease of body, of the body having too much fat tissue. It appears to be more of a disease of body fat and where the fat is located. So you can have a lot of body fat, but if it's all subcutaneous and it's on your hips and your thighs, that might actually be a good thing. But if all of that fat is located in your visceral organs, we know that that's not a good thing, at least when we talk about metabolic disease. So there's a lot of heterogeneity in terms of the composition of fat tissue and where the fat is located. And so it's not surprising that you can have people who have similar amounts of body fat, but that the impact of that body fat on their health can be very different. Which brings us to the problem with the current definition. The current definition of obesity is based on body mass index. Now, where does this body mass index come from? All of you know it's calculated from height and size, from height and weight. So ultimately, BMI is a measure of size. If you tell me someone has a BMI of 50, I know this is going to be someone who's pretty big. But it doesn't really tell me much about the health of that person. In the same way that stepping on a scale doesn't tell me much about the health of a person. So why did we use it? Well, this all started in the 70s. When really from a population study perspective, people were looking for some simple indicator that could be used to measure body composition. It's a surrogate for body composition. And as I'll show you, that works great at population levels, but when you bring this down to the individual, and there's this famous picture of these two obesity researchers, both of whom have a BMI of 22.3. But when you look at their actual body composition based on the DEXA scans that you see on the left and the right, you'll see that one of these people has 9.1% body fat. And the other one has 20% body fat. That's a twofold difference at exactly the same BMI. So BMI does not really tell you much about body composition. It does at a population level. So when you do this across populations, yes, there is a correlation between body mass index and the amount of body fat that you have. But if you pick a BMI level, let's just do this, in this case, let's do this for men. Pick someone with a BMI of 30. You could have 10% body fat, or you could have 50% body fat and still have a BMI of 30. That's a six-fold difference in the amount of body fat. And remember, we're not even talking here about the kind of body fat or the location of the body fat, just the amount of body fat. A six-fold difference at exactly the same BMI. For women, BMI 30, you could have 30% body fat, which is pretty much normal, or 60% body fat, same BMI. So BMI is not an accurate measure of body fat. It works at a population level, but it doesn't work for an individual patient. So using BMI as a diagnostic criteria that tells you this is a person who has obesity or this is a person who has a disease and requires treatment versus this is someone who does not. If you're going to base this on a measure like this, like BMI, which is so inaccurate, you can already tell that there's a problem. And we've known for a long time that BMI does not fully characterize risk. One of the studies I was involved in several years ago was the InterHeart study. The InterHeart study was a large international case-control study where you took people who had an acute myocardial infarct showing up in the emergency room of a hospital. And you would match them to a patient who was in that hospital for another reason. And you would measure the waist-to-hip ratios. And we did this in 52 countries, and it was a large study, 27,000 people. And then you could take all these people, and you can calculate their risk for being in the hospital with coronary artery disease or with a myocardial infarct. And we measured waist-to-hip circumference ratios. Now, what does a waist-to-hip ratio tell you? What a waist-to-hip ratio tells you is basically the fat distribution. The larger your waist-to-hip ratio means there's more fat around your waist, or the circumference around your waist is larger than the circumference of your hips. And you can take those numbers and you can put them in relationship to BMI, and then you can break down the entire population. And here's what we found. When you look at every single BMI category, and you can start from BMIs as low as 20 or less, And within each BMI category, you look at quintiles of waist-to-hip ratios. What you can very clearly see here is that it doesn't really matter what your baseline BMI is. In every single group, the people with higher waist-to-hip ratios, completely irrespective of your actual BMI, are the ones who are more likely to have a myocardial infarct. And in fact, if you look at this, if you take someone who has a BMI of 20 or 23, or let's say 23 to 25, now nobody would consider that to be obesity. But if you have a large waist-to-hip ratio, even at a BMI as low as 23, your risk for myocardial infarct is up here, which is the same for someone who has a BMI over 30 on a high waist-to-hip ratio. And if the goal of your obesity treatment is to try to prevent myocardial infarcts, the question is, well, shouldn't you be treating this person for their increased risk? And I could ask the question, why are you treating these people? So this concept, this notion that we can base our diagnosis and our indication for treatment simply based on heights and weights, measurement of size, is nonsense. It doesn't make a lot of sense. Now this was a study in 52 countries. And we've known for a long time that there are huge ethnic differences in susceptibility for obesity. Another study we did a while ago where we compared metabolic parameters, adipose tissue function, pathology, amongst people who were South Asian and compared them to a comparable group of Caucasians. We did this in Canada. This is the molecular share study. What we found very consistently was that for the same BMI level, South Asians who didn't have obesity, even at a BMI of 23, they had more visceral fat, they had more ectopic fat. This was confirmed with skeletal muscle biopsies. They had larger adipocytes, remember, hypertrophic obesity. They had higher fasting insulins, higher HOMA index as an indirect measure of insulin resistance, higher triglycerides, lower adiponectin levels than Caucasians for the exact same BMI. So once again, why would you use the same BMI level to make the diagnosis of obesity in these two individuals? A lot of the evidence that we have that losing weight can actually be good for you in the long term in terms of mortality comes from the surgical literature. In fact, I think it's fair to say that the bariatric surgeons have the best track record so far of providing durable obesity treatments. A lot of what happens in medicine and what happens in lifestyle medicine is that we get our patients to lose weight and a few years later they put the weight back on and then we blame the patient. That's standard procedure. But bariatric surgery has been around for a long time. And when you look at the long-term follow-up of patients who've had bariatric surgery 20 years and now 30 years ago, what you consistently show is that there are clear health benefits for most patients who have bariatric surgery. This is not to say that bariatric surgery is the best treatment or is the only treatment or is a safe treatment. It's gotten a lot safer in the last 30 years. They've gone from open surgery to laparoscopic surgery. We've learned a lot more about how to manage these patients, how to look after them before and post-surgery. And when we look at those studies, there's clear evidence that losing weight and keeping weight off over time will reduce your cardiovascular risk. But here's the interesting part in this. Yes, the surgical treatments benefit cardiovascular events occur, but they're not related to the initial BMI of the patient. You know, as in a lot of other diseases, you would imagine that people with the most severe disease will get the most benefit. And if you're going to define severity of obesity based on BMI, then you would say people with the highest BMI should have the biggest benefit from weight loss. But that's not what you see in these cohorts. In fact, it turns out that there was actually no significant relationship at all between the weight changes and the health benefits in terms of cardiovascular risk for the individual patient. This basically means I cannot predict how you are going to respond in terms of your cardiovascular benefits of weight loss based on your starting BMI. And this paper actually prompted an important editorial where Edward Livingston, who at the time was one of the co-editors of JAMA, said that all the weight loss is generally desirable. And we can talk about that. How desirable is it? And how strong is the evidence that weight loss is the treatment for obesity? It's not very informative, which basically tells you, if you tell me somebody has lost X amount of weight, I don't know whether that person has gotten healthier, has gotten sicker, or what the problem is. Which brings us to the problem is, which brings us to the clinical issue of, okay, so how do we actually diagnose obesity? And how do we triage patients in terms of saying, well, if you want to treat the people who have the highest risk first, well, then who are these people who have the highest risk? Is it the people who have the highest BMI, or are there other criteria that you need to consider? And so having thought and discussed about this problem, and in fact, I had to think about this problem because when I moved to my current job in Edmonton, they put me in charge of a large bariatric program, and it was a public service. But we had a waiting list of 1,500 patients. It was going to take us 3 years before you could see everybody. So the question was, how do you triage these patients? Who do you see first? And there's several ways of doing this. You can do a first come, first served kind of triaging. Or you can do the largest patients first. Or there could be other methods of doing this. So we were thinking about this, and that's when we came up and said, why don't we come up with a clinical staging system that's actually going to look at the actual health of a patient and not just their body mass index. And so we proposed a staging system. And the staging system was really based on the idea that, you are across the BMI spectrum, you're going to find people who are pretty healthy, and you're going to find people who have, what I call preclinical problems, pre-diabetes, pre-hypertension. Then you've got people who actually have obesity-related comorbidities. And then you'll have people who have end organ damage, and then you'll have people who have probably irreversible end organ damage. And so we used the Edmonton staging system to see whether classifying patients based on their actual health status would be a better indicator of outcomes. And so just to take you through the system, and some of you might have heard of the Edmonton obesity staging system. So you can start off at stage 0. So your BMI is whatever your BMI criteria of obesity happen to be. If it's 30, that's fine. You're going to find people, they have no medical issues, there's no mental health issues, there's no physical issues, they feel good about themselves. That's stage 0 obesity. And then you have this sort of preclinical, pre-diabetes, snoring, it's not quite sleep apnea, occasional heartburn, it's not enough to call it reflux disease. And then you have the people with stage 2 obesity. These are the people who actually have a clinical diagnosis related to their obesity. And there's a long list of those conditions. This could be fatty liver disease, it could be diabetes, it could be hypertension, it could be osteoarthritis, long list of things. And a lot of these conditions can progress to end organ damage. And we're talking about clinical diagnosis of end organ damage. So these are not complicated, sophisticated tests that you have to do. So a patient who's got retinopathy, that's end organ damage. A patient who's got nephropathy, that's end organ damage. Patient who's got coronary artery disease, that's end organ damage. A patient who needs a joint replacement, end organ damage. So we consider that stage 3. And then there's what you can consider to be end-stage obesity. End-stage obesity means these are patients who've got probably irreversible end organ damage. So even if this patient went to have bariatric surgery and lost a lot of weight, you're probably not going to fully restore the function of the organ. Okay. So we put this out there. And then the big question was, well, what do you do with these people? First of all, do these people exist? And is it true that they are actually low-risk people? I mean, everybody agrees that when you have people who have end organ damage, they're not healthy and their risk is probably high. But what about these guys? Should we be treating people with stage 0 and stage 1 obesity? So we said, that's a great question. Let's go and look at this. And we had the opportunity of taking large data sets and applying the Edmonton staging system to this. And I'm just going to show you one of the studies. This was using the data set from the N. Haynes study, which is a representative survey of the US population where you take baseline measures of health. And you can link those baseline measures of health to the death registries. And so what you get are survival curves. So what you see here is basically a Kaplan-Meier analysis based on BMI classes. Class 1, Class 2, Class 3 obesity. So this is just BMI. So if you just take the entire population and you just put them into these little boxes based on body mass, and then you follow, then you count body bags. You're basically looking at survival here. You can see that these lines, about 20% of the people you start out with after 200 months is 18 years, so we're looking at a long time period here. Yeah, you lose people. But these lines overlap, which means that if you were to call my office and say, hey, Dr. Sharma, I got some guy here, BMI 37, Class 2 obesity. What's his prognosis? How long is he going to live? I don't know. Could be anything. Now, if you take the same population and you apply the Edmonton staging system, these curves look very different. And the surprise is not the fact that people who have stage 3 obesity, who have end organ damage, are dying. Yeah, you lose half of them over 20 years. But the interesting finding was here that if you look at the stage 1 and stage 2 obesity, they have low risk, even over a time period of 20 years. So if you treat people with stage 0 obesity, you're not saving lives, at least not in a 20-year time frame. Well, that's a long time frame. Now, you might think, well, who are these people with stage 0 obesity? I mean, those must be the guys who are just sort of borderline obesity, maybe BMIs of 30 or 31.2. It turns out that across every single BMI class, the finding is the same. So whether you're looking at people who are in the BMI overweight category, so this is people who have BMIs between 25 and 30. If you have end organ damage, you don't do well. If you're healthy, you can pretty much go on forever. And the same is true for class 3 obesity. Now remember, class 3 obesity is BMI 40. So even in people with BMI 40, you'll find those who have end organ damage, half of them are going to be dead in the next 20 years. But then you've got these guys here, class 1, class 2 obesity, low risk. So clearly BMI is not telling you the whole story. You have to have the clinical assessment that will then tell you who's in what risk category. And that has huge implications for when you set up a program, how you make the diagnosis, how you allocate resources, how do you do triaging, who gets to see the doctor first, who gets medication, who gets bariatric surgery. And ultimately, the question is, what's going to be the population impact of actually providing those services? So when you take this classification system and you spread it across the population, again, we're talking the US population here. Yes, we have class 3 obesity, which is your BMI 40. And most people with class 3 obesity are going to be 2s and 3s. But even with class 3 obesity, BMI 40, you're still going to have a few people there who are stage 0s and stage 1s. In fact, if you add them together, it's about 1/5. So let's say you find the resources to do bariatric surgery on everybody with class 3 obesity. You take 6 million people and you do surgery on everybody. Remember, these are the numbers from the US. Well, you could argue that maybe 1 in 5 of those people, and that would be 1 million people, are now having surgery, although they're in the low risk. And here, clearly, the risk of having surgery probably outweighs the risk of not having surgery. You're not saving lives. On the other hand, there's good evidence that the people with stage 2 and stage 3 obesity, they should probably get treatment. But even if you did all of them, you're still going to be missing a lot of people who probably need treatment. And where are those people? Well, they're actually here. Half of 50 million is 25 million. They don't even get diagnosed as having obesity, and they don't even have access to obesity treatments, but their risk is exactly as high as the risk of these people. And this has huge consequences for thinking about who are you going to treat. Well, you can treat all of these people. You're over-treating a substantial number of people. But you're missing out on most people who can, in the population, who will actually stand to benefit from treatment. And that's a real problem. So what the Edmonton obesity staging system does is it makes us reflect on this whole issue around how do we actually diagnose obesity and who do we treat. Now, the Edmonton obesity staging system might have other uses. Here was an interesting study which illustrates a couple of points from colleagues from bariatric surgeons in Germany who looked at a cohort of about 500 patients undergoing bariatric surgery at their center, and then they applied the Edmonton staging system. And I apologize for the numbers being very small on this table, but I'll take you through the important information here. So what you see here are the EOS classes for the 500 patients who underwent bariatric surgery. And as in most bariatric surgeries, you can say most people who get bariatric surgery are in the stage 2, stage 3 category. Okay, and you can see that here. So about 70% of the patients who had bariatric surgery are EOS 2, about 12% EOS 3, and then there's a couple of zeros and ones where you can argue, did they need surgery, should they have gotten surgery? But what's really important in this slide is actually this, the fact that when you look at the BMI categories, sort of across the EOS stages, it's exactly the same. You're going at 49.5, which is 50, 50, 50, 50. So if you were just saying, let's operate on everybody with BMI 50, you're going to have people with EOS 0, and you're going to have people with EOS 3, and you're going to have people with EOS 4. Everybody has a BMI 50. So right here you can see that BMI 50 doesn't really tell you much about the actual risk of a patient. And when you look at complications, who has more complications from surgery? Well, it's the EOS that predicts complications. It's not size. Remember, they all have the same size. But here you've got people with BMI 50, they have bariatric surgery, there's no complications. And here you've got someone with BMI 50, stage 3, they get bariatric surgery, you've got 22% complications, which makes a lot of sense. These are people who have endocrine damage, they're sicker people. So even in terms of predicting the risk, and now we are coming back to this issue about who should actually get surgery, who stands to benefit, how do you select the patient, how do you counsel a patient and get consent about their individual risk? It's not dependent on their BMI. Everybody here has a BMI of 50. It depends solely on their comorbidities. And that's where EOS comes in. So that's one use of EOS. Let me show you another one. This was a study that was done by gynecologists. This was actually done by the obstetrics program in Toronto. And the issue here is that when you look at fertility treatments, and we all know that excess weight can reduce your chances of pregnancies. And one of the criteria that's often posed, at least in Canada, when you go to fertility treatments, is that there's a BMI cutoff. In some provinces, that's at 35. If your BMI is over 35, you do not qualify for fertility treatments. And the argument there is that you're not going to be successful because you're too big. So very often patients get told you need to lose weight before we'll do the fertility treatment. So we said, okay, let's see how EOS performs in that context. And these are young women. These are women who are trying to get pregnant. So when you look at the rate of pregnancies, these are about 100 pregnancies, or 100 people trying to get pregnant. And you look at the success of fertility treatments. You see that based on body mass index, these are the different categories of BMI starting from overweight, class 1, class 2, class 3. The average rate of success, reproductive success, that is pregnancy rate, is about 15%. Note, for BMI over 40, it's almost the same as for BMI 25 to 30. So BMI doesn't actually determine outcomes. If you apply EOS to this, and remember they're relatively healthy, but you'll still find people with EOS 2 and 3. Looks very different. And now you can see that if you have an EOS score, if you're a stage 0 patient, your chances of success, irrespective of whatever your BMI is, if you're an EOS 0, you have a 50% chance of getting pregnant. If you're an EOS 3, your chances are virtually 0. So again, it's not BMI that determines your success rate, it's the comorbidities. And in Canada, at least now, we've gone on to routinely using EOS letters. When I dictate a letter on a patient, I say this is a patient with class 3 obesity, stage 4 or stage 3, and then I list the comorbidities that make them a stage 3. That's how I dictate my notes. And this does have consequences for how you triage patients and how you treat people. When you look at the Canadian obesity sort of management guidelines and the tools that we put out, part of your assessment is assessing obesity-related risk, and that's going to help you make a decision. And it's not that BMI is no longer important. We still have BMI over here. But a lot of the treatment decisions are going to be based on the staging system. This is a simplified version of the treatment system. And we've now seen over time that others have started adopting this system. So for example, when you look at the guidelines from the American, they're now called the obesity medicine folks, they've included EOS in their algorithm. And the Finnish society has done it, the Swedes have done it, the Germans have now done it. So you're seeing that we are starting to use this health-centric definition of obesity, where you're no longer defining whether someone has obesity, whether someone needs treatment for obesity, just based on a measuring tape or stepping on the scale or taking a height and weight. No, you actually have to have an office visit and do assessments in the patient, and then you create a score, and then you decide who needs treatment. So you can see the Edmonton staging system right up there. All right. Interestingly, this does not just work for adults. I'm not a pediatrician. My clinic is adults. But I have colleagues who've come up with a score for pediatrics. And the pediatric score does not have a stage 4. We don't have terminal obesity in kids. But they have a stage 0, a stage 1, and a stage 2, and a stage 3. And they've just published, and this was out in the Lancet Child and Adolescent Health just a few months ago. They looked at a large cohort of I think it was about 850 pediatric patients presenting at all the pediatric centers across Canada. And here are the findings. I'll take you through them. So on the 850 patients, 64 had severe obesity based on BMI class, and 80% were EOS pay. So most of them were actually 2 and 3. And what was the most frequent comorbidity? The most frequent comorbidities were not the metabolic comorbidities, but it was actually the mental health concerns. And then there was metabolic problems, and then there was social milieu problems, which includes things like bullying, being bullied. And then there were some mechanical health issues. That's joint pain, sleep apnea, reflux disease. And here was an interesting finding. When they looked at mental health issues, and we're talking about anxiety and depression and attention deficit disorder and binge eating disorder and all of them, there's a whole bag of mental health issues that you haven't related to excess weight. They were actually equally distributed across classes. So you could have someone who's got, BMI 30, has depression or ADD, or you can have someone with BMI 40 has depression or ADD. So as far as the mental health issues related to obesity, they were not dependent on BMI at all. It was evenly distributed across all BMI categories. The metabolic health issues, there was a correlation. So the kids with slightly higher BMIs had slightly more BMIs. But if you looked at it, there was a lot of kids, even at the lower ends of BMI, who had metabolic problems. In fact, the only problems that were clearly related to excess BMI, which were really far more frequent in the kids that were larger, was bullying and the mechanical issues. They're rare in kids, but those were clearly related to BMI. The metabolic problems and the mental health issues were completely unrelated to BMI. And that's important to know in this context. And even if you went down to the kids with class 1 obesity, there were a lot of kids with class 1 obesity who had stage 2 or stage 3 obesity based on the EOS-P. So even in pediatric populations, it's not enough to have growth curves and charts and measures of BMI. And you have to actually take a mental health history, and you have to look for mechanical problems, and you have to look for metabolic issues. And then you decide, which are the patients who are going to need the most attention first. They probably all need attention, but we have limited resources. Which brings us finally to the question of how do we define obesity? How do we move away from the numbers? And I haven't had the time to talk about the implications of calling it a disease and why we need to do this and how that has a ripple effect across the healthcare systems. So how do we go beyond just numbers? Well, if you look at the current definition of obesity, the World Health Organization definition, and this definition has been allowed forever, it talks about obesity defined as the presence of abnormal or excess fat that may impair health. And what's very clever about this definition is that they don't talk about the magnitude of the fat. They talk about even the presence of abnormal fat. So you can have a few extra pounds of visceral fat. If that's affecting your health or may impair your health, that could be obesity. But there's a problem with this definition if you're going to use this as a disease definition. And the problem is here. The problem is may. Because what does this mean? This means it may or may not impair health. Well, if it doesn't impair health, then it's not a disease. Then it's a risk factor. So if you want to come up with a clinically definition, if you want to use a diagnosis, then you can't work with things like may. So you actually have to change the definition, and it's very easy. All you have to do is take away the word may and make it impairs health. So the presence of abnormal excess fat that impairs health, that's a disease. The presence of excess body fat that's not impairing your health, well, that might be a risk factor for disease, but it's not a disease. And that's important to consider because as we start having these discussions, are we medicalizing the problem? Does everybody need treatment? Is it a chronic disease? Where do the resources go? We have to be very precise in our language, saying, what is obesity? Well, obesity is not being fat. It's having a medical condition, a health impairment that is directly related to your body fat. That's what obesity is. And I can't do that with a measuring tape or by stepping on a scale. I have to actually see the patient in my office and do the tests, and then we can have a conversation about whether there actually is a health impairment. And this again has consequences for the treatment. Because in the treatment, it's not about weight, it's not about losing weight, it's ultimately about improving the health of the patient, but I can only improve the health of a patient when there's a health problem. If I have a healthy patient who doesn't have a health problem, there's nothing for me to improve. That person does not need treatment. So what I hope I've shown you is that the Edmonton obesity staging system, and there might be other systems that can do this. This was the system we came up with, and we've got quite a bit of data to back this up, but maybe there's other systems out there. Maybe we can make things a little bit easier. But it's clearly a better predictor of obesity-related risk than BMI or waist circumference or weight ratio or metabolic syndrome, that covers the metabolic aspect, but it doesn't cover mental health or back pain or liver disease. And at least in Canada, we've moved to the point that we more or less recommend that some form of staging be regularly used in making the diagnosis. And I hope that you'll see that using this kind of a health-centric approach to diagnosing obesity makes a lot of sense and can actually guide treatment much better than simply knowing how big someone is. If you want more information on how we came up with the system or other aspects, I do have an obesity blog that I used to write daily. I've stopped writing it daily, but there's about 2,500 articles on my page here that covers a whole bunch of things around obesity.
How do you reconcile when you apply the EOS, if you apply it and have a non-fatal disease outcome in mind, it seems as though you need to target the lower stages. If you have a fatal or a hard endpoint in mind, you kind of ignore the lower stages because, you know what I mean? How do you reconcile that strike that balance?
Well, it's always a problem that you have in medicine is who do you treat first? For most treatments, as much as we would like to have the resources to do prevention on everybody, resources are limited. They're expensive, and almost every treatment approach also carries not just a cost but also a risk. And when you start looking at risk-benefit ratios of treatment, even telling somebody to go exercise has a risk. They fall down, they break a leg. So there are no risk-free treatments. You tell people, to restrict their calories, they go nuts, and now they're starving themselves and they get all kinds of nutritional deficits. So when they're doing this, without guidance, without help. So every treatment has a risk. And so when you're trying to balance what is the risk and the cost of treatment you say, okay, if you want to be safe, you focus on the people who are the sickest, because that's where you're going to get the biggest bang for your buck. Now that's an acute medicine type approach. Because every health economist will tell you that if you look at the people admitted to the hospital, it's 20% of the patients who create most of the cost, and they're usually the sickest people. Okay, so you focus there first, which is what we've been trying to do with bariatric surgery. But bariatric surgery is not scalable. You can't do bariatric surgery on 6 million people. So we need other treatments. But even with those other treatments, you're going to still have to make that decision. Who do you start first? Now, if I had the resources, I would probably start with everybody. I would probably start with people with BMIs of 23 at stage 0 and start saying, okay, well, what's going on over here? At least I would monitor them to make sure that, they stay at stage 0. But most healthcare systems don't have those resources. So you're kind of starting to say, well, who are the people where we know we're going to have the biggest impact? And those are going to be the people who have the most severe forms of obesity, not based on size, but based on their actual health status. So the stage 2, stage 3, etc.
Have you had any experience using the staging system and linking that up with appropriate funding to support that? Or how have those conversations gone?
Well, we haven't had those conversations because the funding is so small that it's almost pointless, right? I think as we start having more and more of these services and start rolling these out to more and more people, those questions are going to become really important. I mean, right now we have a waiting list in our center for about 2.5 years to come and see us. So, and it's so few people who actually have access to treatments that you are almost say, whoever gets it, good for you. But as we start thinking about this, to say, okay, if this becomes routine to provide the same kind of services within healthcare systems for obesity as we are providing for diabetes or heart disease or any other chronic disease, then those questions become really important.
I imagine it'll be complex at the lower end of BMI, but high risks.
Yeah, but we do that for a lot of things. There are some people who say, even someone who has prediabetes needs treatment, and other people say, well, no, you know what, prediabetes, we'll monitor the people and then actually wait for diabetes, and when they have diabetes, we'll start them off on medications, right? So there's an ongoing argument for virtually every disease at the lower end. When does snoring become sleep apnea? When do you start putting them on a CPAP machine, right? So, and then you can disagree about that. But I think we don't have to have that discussion as long as we still have all these people where there's no question about whether they would benefit from treatment. Well, let's treat them first, and then when we run out of patients, let's talk about the others.
Thanks for a fabulous talk. That's very, very interesting. When you show those Kaplan-Meier curves of stage of EOS level and that beautiful separation with respect to mortality at the end of, say, the 20 years, what about when you take those people with stage 4 versus 3 versus 2 and intervene with bariatric surgery or medical treatment? What do you see in terms of mortality benefit? Have you looked at that in terms of the EOS stage? And my question then is, could it be that if you intervene with stage 4, actually that's not the bang for your buck? Those people are going to die anyway because of their end organ complications. Should you intervene earlier?
Yeah, you should probably intervene earlier. I can't answer your question because we haven't, and others haven't really applied this kind of a framework to the bariatric surgery literature. But if you look at the question of why has it taken so long, why did it take 20 years or 30 years to demonstrate the benefit of bariatric surgery, I'm guessing is because a lot of people have had bariatric surgery who probably didn't stand to benefit very much in terms of outcomes, and that surgeons perhaps, at least in the early days, were perhaps shying away from the patients who would have the biggest benefit. So I think that dilutes the that dilutes the overall picture. But it makes a lot of sense that when you have people who have a problem, and you see this if you just look at patients who have diabetes who have bariatric surgery, you very often see that there's a vast improvement in their diabetic control or even remission. It doesn't cure it, but it gets a lot better. And obviously they're going to have much benefit. Now, if you don't have diabetes and have bariatric surgery, well, of course your diabetes is not going to get better because you don't have it. So you have to take this approach. and this comes back to the point that I was making, that when we come up with treatment plans for patients, we have to say, well, what's the whole overall goal of treatment here? It cannot just be, here, let's set a target weight and get everybody to lose that amount of weight. It has to be ultimately to say, okay, what is the medical problem we are trying to treat here, right? What is the problem that the patient has? One of the things we do know is that different complications of obesity respond to different levels of treatment. So you can get a huge bang for your buck with a 5% weight loss if all you're interested in is metabolic problems. Blood pressure gets better, diabetes gets better, lipids get better. But a 5% weight loss does virtually nothing for sleep apnea, right? So if the problem that you're trying to solve is sleep apnea, well, then talking about a 5% weight loss is a waste of time. And you've got to start thinking, okay, I'm going to need at least a 15% weight loss here. Well, I'm not going to get that with, diet and exercise, at least not in a sustainable manner, right? So thinking about the complications also then frames your thinking around what is the proper treatment, or what is the level of treatment, or what's the dose of treatment that this patient is actually going to need.
Arya, Tony, great talk as usual. How does EOS staging apply following bariatric surgery with weight regain and the need for either further surgery or further adjuvant pharmacotherapy?
Yeah.
So in other words, you've moved someone from stage 3 down to stage 1, let's say. They've regained weight. How does EOS apply in that particular instance?
Yeah. It's a great question. I mean, I can only give you a philosophical answer. I mean, I would say that if you have reappearance of the health issues, which were the reason for having bariatric surgery in the first place, you need to think about adding further treatments, right? And now this could be regained, but this could also be a patient who has bariatric surgery who's lost maybe 20% of their body weight but still has issues, where you think an additional 10% weight loss might get them there. And that's when we start thinking about even combining medical treatments, behavioral treatments, surgical treatments. See, I don't see them as silos. I don't see this as being, once you have surgery, then that's it. Or here we just do lifestyle. It's you combine these things. I mean, we do this for diabetes patients. I mean, you give lifestyle, and you do diet, and you go exercise, you give medication, then some guys get a pump, some guys get a pancreas transplant. I mean, you have to sort of, look at everything that you've got and then individualize treatment.
Mine wasn't a question to you, Arya. It was just really a comment to something that Evan said earlier. My name's George. I'm the Obesity Management Network Chair for the RACGP. It was just really to clarify that confusion that you alluded to earlier in your talk. I think the confusion that some GPs do have about using chronic care plans for people with obesity stems historically from more than 10 years ago, where obesity was actually listed as an exclusion. That no longer exists, and it hasn't for at least 5-6 years from my recollection, if not a bit longer. So we have confirmed it with MBS. We've also confirmed it with the College of General Practice. As GPs, we can and we should be using chronic care plans and also TEM care arrangements to be able to help people with obesity, because they've got a chronic progressive disease. The criteria says they've got to have it for at least 6 months. I've yet to meet anyone with obesity for less than 6 months. The other criterion says that they would benefit from a multidisciplinary team. We know we've all been talking about the team approach. So I hope that clarifies any confusion that might have been in the room. Thank you.
All right, I just had one question. Excellent talk as usual. My name is Remy from the Blacktown program. The Edmonton staging system does phenomenally when you compare it versus BMI and mortality, and predicts surgical complications after surgery. But we know that people with a higher BMI, may not necessarily die depending on the severity of disease, but the quality of life is a big issue, and the cost as well.
Sure.
So you can have people, has Edmonton ever predicted cost and quality of life?
Yeah, so quality of life kind of figures into the system because one of the criteria of EOS is also functional ability, right? Where things get murky is when you have a patient who's very unhappy about their size but they're otherwise healthy. That's where you'd say, well, being unhappy with your body, despite the fact that you're actually healthy, is a problem. Again, that's not unique to obesity. I mean, a lot of people are unhappy with their bodies. They think their noses are too big or their ears are, too far apart or, got too little hair, whatever it is. that can become a medical problem at some point where you say, if it's now causing me to not leave the house anymore and not be able to find a job, and I've got, social anxiety disorder because of my appearance, that then becomes a pathology, right? But for most people, we are saying, we're not in the business of making, people happier with their bodies. That's not, it would be nice, and we certainly have learned a lot from the, from the body positivity movement, which I think is a great movement, and we need to talk about it and see how that incorporates in it. But that's where things get a little bit murky. Fortunately, clinically, it's usually not that difficult. I mean, at least for the patients that I see, most patients, they have a very clear indication. It's okay, here's the health problem that you have, and this is the one we're going to try to fix.
Do you mind if I just add in an extra point? Arya, to Rami. Whilst maybe Arya's group hasn't done that kind of research, PricewaterhouseCoopers, in conjunction with Obesity Australia, has published the cost of obesity, and in that they looked at medication and also bariatric surgery and how many years it takes to recoup the money to make it cost neutral and cost effective. And for memory patients with type 2 diabetes, within a handful of years, you've recouped the money, because when you look at improvements in their health, fewer complications, fewer medications, etc., you get a quick return on your money. So the data, and it's Australian data too, does exist, and I'm sure we can provide that for you if you like.
Yeah, so if you'll allow me to just make one comment on the money. I understand that, money is limited, and we have to be very careful and judicious on how we spend money and how we allocate money in the system. But I'm fundamentally opposed to the notion that the only real reason we have to treat obesity is because it costs so much, and the only argument for treating it is if we can save money. Because I think that has to do with the stigma and the bias. We don't treat cancer to save money for the system. When people come with their heart attacks, it's not, we got to treat their heart attack because we'll save money. No, in fact, actually, if you let them die, it's a lot cheaper. Okay? So I don't see why, when it comes to obesity, we are discussing cost savings for the system, which may or may not be there, but it's great if they're there. But even if they're not there, I think we still have an obligation to provide a treatment. After all, treatments cost money. And so it's nice if we have an economic argument, and we have to think about, okay, what's it going to cost, and can we do this in the most cost-effective way? But to say we're not going to treat obesity in someone because it doesn't save money for the system, well, then you shouldn't be treating cancer, because that doesn't save money for the system. You shouldn't be treating people with heart attacks. That's not saving money for the system, right? So this idea that, well, we'll use treatment for obesity if treatment for obesity becomes a cash cow for the system, I think that whole notion is discriminatory, right? And so I refuse to talk about whether this is cost savings or not. If there's a cost, find the money. And I can tell you there's enough money in the system, because we do waste a lot of money in the system on doing a lot of things that maybe we shouldn't be doing.
Yeah. Could I go back to Rami's point? I think what Rami was, and I apologize if I misunderstood your point. You were questioning whether or not you were questioning the value of the BMI for identifying patients who have limitations, and you think it's still a useful one. But I think applying the EOSS could still be applied in the same way. That is, and in fact, it provides a stronger argument for addressing or treating patients at the lower stage of the EOS, because they're the ones who are going to survive and live longer. And as I'm sure you and other physicians I speak to who are managing patients who are with a BMI of 50 plus, they're more concerned about their function, as you say, their quality of life, getting a job, getting a girlfriend, or boyfriend or whatever. They are their primary sort of motivator. They're not concerned about survival 20 years later.
Thank you, Catherine Samaras, St Vincent's Hospital, Sydney. Thank you, that was a fantastic talk, and one of the points that I really enjoyed was your encouragement of the stratification, and from our point of view as clinicians, a professionalism that really stratifies, classifies the various aspects of disease that these people suffer. And if I can encourage everybody in the room, when people are doing the correspondence that goes to allied health professionals or other professional people who underestimate the impact of obesity, whether it's cardiologists or hepatologists, that we really mark out all the comorbidities. So it's understood that these are not separate things, but they all come in under the factor that obesity is the driving factor. And I think that that gives us far more impetus to try and have cohesion between allied health services, link in with other facilities and get other clinicians working with us rather than just thinking, yeah, they've got breast cancer, but, you know, they're also obese, but let's just focus on the breast cancer and avoid the fact that they've gained 20 kilos, you know, on their anti-estrogen therapy, for example.
Yeah, so thanks so much for that comment. So I alluded to it briefly. So in my own notes, I list obesity-related comorbidities, right? So the primary diagnosis is obesity, comorbidities, type 2 diabetes, reflux disease, osteoarthritis, etc., you know, sleep apnea. Those are listed under obesity. Obesity is the main category. These are just, I mean, this is like if you had your main category is diabetes, but the patient also has nephropathy and kidney failure and, you know, a whole bunch of other things, right? So obesity is the overlying chief complaint, whether it's a complaint or not. And then you list everything that's related to it as under obesity. And then, you know, that's how you do EOS, right? So it really does change your focus in terms of not looking at these as siloed problems that patients have. No, they're actually all related. If I could just cure their obesity, I could cure all of those other issues.
Hi, thank you so much for your really insightful talk. A really good insight on the new classification in terms of how to define obesity. So I come from a pharmacy background. So, you know, traditionally we've always been using BMIs, you know, for dose modification, how the drugs affects the pharmacokinetics, and so on and so forth in obese patients. So what's your take on like EOS? Like, does that apply to, or like, would that help apply, you know, to help dose modification as well, or do you reckon still with BMIs would be the way to go? Yeah,
it's a great question. I mean, for the drugs that are traditional, you would base, you know, based on BMI or body surface area or whatever the criteria you use, based on algorithms that were studied that, you know, tell you about the pharmacokinetics. I'm not exactly sure how EOS would fit into that. I mean, what I do know is, for example, that in patients who undergo bariatric surgery, you can markedly change the pharmacokinetics. So a lot of these formulas don't really apply to that population. So it's a great question, but I don't have a good answer for it. I don't quite see how EOS would fit, but I'm quite sure that you have to have some way of, you know, redefining what those is, at least for the medications where that becomes relevant. And it's absolutely relevant for the post-bariatric surgical population, definitely.
Thank you very, very much. Thank you.